Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by BWIL Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please introduce yourself in the chat by entering your full name, affiliation, and email. Please remember to stay muted unless you are speaking. We do encourage using the chat and or the raise your hand feature to pose questions or share perspectives throughout the session today. We would love to have everyone with their cameras on as this does increase connection and engagement, though we do completely understand that some situations don't allow for that. But if you are able, we'd love to see everyone's lovely face. If you're having connection issues, please privately chat our wonderful Echo IT Karen for further assistance. As a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point throughout the session, and this includes names, addresses, birth dates, or any other identifiable information. And also, the slide presentation from today's session will be uploaded and shared on the iEcho platform for your future reference, and it will also be shared in a post-session communication email. At the end of the session, the Echo team will send out a post-session survey link. We kindly ask you to complete it as it does provide us valuable insight and feedback on how to refine these sessions to better address your priorities and interests. And finally, Echo is an all-teach, all-learn environment. We encourage everyone to participate in the conversation today and raise questions throughout. Let us always make every effort to continue having the space that is respectful and safe for all of us to learn. And so with that, we'll begin with some team introductions. We will start with Dr. Kowalczyk, who's also our lead for today.
Hello, I'm Alicia, Dr. Kowalczyk. I'm boarded in family and addiction medicine. I'm an associate professor here at Baylor College of Medicine and medical director for Santa Maria Hospital. Welcome.
Thanks, Dr. Kowalczyk. We have Dr. Walker.
Hi, good afternoon, everybody. Crystal Walker, PA with Doctor of Medical Sciences, and I am currently the Director of Substance Use Disorders Treatment Services for My Health, My Resources of Tarrant County in Fort Worth, Texas, and I'm excited for the Dr. Wakhlu pack today.
Thank you, Dr. Walker. Yes, and finally, our didactic presenter for today and also Hub team member, Dr. Wakhlu.
Hi, it's Sidarth Wakhlu. I'm an addiction psychiatrist at UT Southwestern. I'm a professor of psychiatry here and interim chief of the addiction division and the director of the addiction psychiatry fellowship here. So welcome, everyone.
Thank you so much, Dr. Wakhlu. And for those that have attended, I do see many introductions coming in through the chat. Please keep those coming. We love to see where you're joining from. And so with that, we'll get started with our didactic presentation. Dr. Wakhlu, the floor is yours.
Thank you so much. Can everyone hear me well? Is it good?
Yes, we can hear you, and the slides look great.
Okay, wonderful. All right. So I'm going to talk about basically drug testing today. And the next slide, please. I do not have any disclosures. Next slide, please. So these are my objectives. So the primarily talk about the utility of drug testing in clinical practice, discuss the various methods of testing, and then discuss metabolism of different drug classes and false positives, and also how I have a couple of slides on how to present information on the results of drug testing on how to approach patients with drug testing. Next slide, please. Yeah, next slide, please. So what is the utility? How is drug testing useful? Again, drug testing is not it's a management tool. It's a diagnostic and management tool. It's not a COTU tool. The goal of drug testing is to help our patients do better and document adherence to an agreed upon treatment plan. aid in the diagnosis of a substance use disorder. It's also a good tool for patient advocacy and also to prevent and minimize diversion. Again, the goal of as you can see, the goal is again patient safety, patient well-being, and patient safety. Next slide, please. So the types of testing we have non-federally regulated testing. We have federally regulated testing, non-federally regulated testing, and then we have clinical testing. So what is federal drug testing? It's primarily for federal employees and federally regulated industries like the railways, the Nuclear Regulatory Commission, the people who apply for CDL licenses. So all federal Department of Transportation, all the federal industries are basically managed by the federal electric testing. So, and we have what we test for is the federal 5, which is primarily cannabis, cocaine, opioids, PCP, phencyclidine, and amphetamines, methamphetamines, and MDMA or ecstasy. And there have been some recent changes in federal testing. It has earlier federal testing would only test for opiates, which means they only test for the morphine metabolite. But now the opiates have been replaced by the entire umbrella of opiates, which includes now testing is done for oxycodone, oxymorphone, hydrocodone, and hydromorphone. So in the past, someone could be misusing or abusing hydrocodone and still be able to pass a federally regulated test, but that's not the case now. And positive testing is done based on immunoassays, which are presumptive positive, and they're confirmed by what we call GCMS and LCMS. GCMS is gas chromatography mass spectrometry, LCMS is liquid chromatography mass spectrometry. And I'll talk more about immunoassays and mass spectrometry in later slides. The cutoff concentrations for federal testing are much higher as compared to clinical testing. The clinical testing morphine cutoff is about 300 nanograms per ml. And in federal testing, as you can see, it's about 4,000 nanograms per ml, because the assumption in federal testing is that most people don't use illicit substances. And in clinical testing, the assumption is that most people are in for SUDS and for clinical care. So the cutoffs are much lower. The Department of Health and Human Services also approved oral fluid testing with the DOT's final rule effective from June 1st, 2023. However, employers cannot use oral fluid testing for DOT-regulated testing till labs and collection devices are certified. And this was supposed to happen by February of last year. And federal testing requires split specimen and chain of custody. Split specimen means that a donor, it's called a donor, it's not a patient in federal, it's a donor, gives two samples, gives a sample, it's split in two cups, cup A and cup B. Cup A is tested, cup B is stored for a period of 12 months for later testing if the donor contests the results of testing of sample A. So that's why it's a split. And a chain of custody means there's a collection site, the sample is sealed, signed by the donor, signed by the collector, and then sent to the lab site. And the lab site will only accept the sample for testing if the entire specimen is intact. If there's no the tape is intact and the initials are showing clearly. If there's any kind of breakage there, then the sample will not be tested. Next slide, please. And then we have non-regulated federal or forensic testing, which is examples of which are child custody cases, your driver's license reinstatement, sports testing, pre-employment testing, random workplace testing, testing in the criminal justice system, and insurance testing. And this is the non-regulated forensic testing. Again, like the federal testing, requires a split specimen and a chain of custody, but the scope is much beyond the federal 5. Forensic testing is very very extensive, and as you know, sports testing, which is done by the WADA, which is the World Anti-Doping Agency, their testing is so extensive. They can test for Benadryl, for gabapentin, for beta blockers, you name it. Sports testing is so extensive, and then we have clinical testing that I'll talk more about. Next slide, please. What are the biological specimens that we use? Urine is the most commonly used biological specimen. Its window of detection is 1 to 3 days, could be 1 to 5 days, but with the exceptions being cannabis, which, as you all know, can stay in for weeks or months, depending on chronicity of use. Phencyclidine PCP present for about 7 to 10 days, and ketamine also, which is a close cousin of PCP, also present for about 7 to 10 days. Urine testing is inexpensive. It's can easily be done in a clinic setting. It's less invasive. Then we have blood and serum. Blood and serum, they're expensive, they're invasive. The detection window is limited, and the results take time to come back. Next slide, please. We also use hair testing, which can extend detection from weeks to months to years. And head hair grows at an average of 0.5 inch per month. Therefore, 1.5 inch hair sample detects up to 90 days, drug use up to 90 days prior to testing. And the initial screening and confirmation requires about 100 milligrams of hair, which is about 90 to 120 strands. It's a good chunk of hair. I've had some female physicians who are being monitored by the Texas Physician Health Program, and they occasionally had hair testing, and they really, it kind of affected their self-esteem, is because they, like I said, they took a good chunk of hair, and they were pretty shook up about the experience, and it takes about 7 days for the drug to reach the hair shaft, and the hair is cut as close to the scalp as possible. So only the strands of hair above the scalp are tested, and not the actual hair follicle. And there are also controversies surrounding hair testing, because how do you differentiate between consumption and external contamination? People who have darker hair tend to concentrate more of the drug. So because the more melanin you have, the more the drug you concentrate, and then effects of bleaching. And so again, some controversies regarding the hair testing, but has value in some circumstances. Next slide, please. And then oral and saliva testing. Oral fluid test will detect drugs in a patient donors immediately after use, and this makes the oral testing ideal for a broad range of testing situations, ranging from pre-employment to reasonable suspicions to post-accident testing. So that's its greatest value is in that post-accident testing scenario. Oral fluid specimens are considered to reflect circulating drug concentrations. Drugs are detected earlier, but for a shorter period, just about 2 days or less. But collection is easy, it's convenient, it's less embarrassing for patients. Patients can put adulterants in their mouth. Food and beverages can interfere with oral testing. And patients need to refrain from eating or drinking for about 10 minutes prior to specimen collection. And a buffer solution is needed to inhibit bacterial growth. So as you know, the oral cavity has a lot of bacteria, so we need a buffer solution to inhibit the bacterial growth. Next slide, please. And lastly, we have sweat testing, or sweat patches. It involves wearing an absorbent pad on your skin that's collected and tested after a certain amount of time. The results provide information on how much of a substance the person has consumed over the entire time they wore the pad. So unlike other forms of testing, which are retrospective, sweat patches are almost, it's prospective, or what you have used in that time period. Window detection is about 10 to 14 days, and they're relatively non-invasive and difficult to tamper with. If you take off a sweat patch, it just puckers up, and then you can't put it back on. It just becomes and it's difficult to put back on, but it does have some low sensitivity for detecting illicit opioid use. Next slide, please. So I earlier talked about testing methods. We have the basic point of care testing is the immunoassays, which is based on the principle of competitive binding and uses antibodies to detect the presence of the drug or the metabolite in urine. a known amount of antibodies and drug labeled with enzyme is added to the urine sample, the drug in urine will compete with the labeled drug, and the amount of enzyme labeled antigen that binds to antibody is inversely proportional to the drug present in urine. The advantage of immunoassays are it's simultaneous. You get results quickly. They're in clinic and rapidly test for drugs in urine, and it's relatively inexpensive. A urine cup generally costs from anywhere to $5 to $7. Disadvantages are it tests for drug classes, not specific metabolites. So it's hard. They can't tell you which benzodiazepine, they can't tell you which opioid. It overall gives you the entire class, but not specific metabolites. And again, the question of high false positive rates because of cross-reactivity. Next slide, please. But immunoassays are good for, especially for cocaine, because testing for the cocaine metabolite, when people test for cocaine, it's 99.99% they've done cocaine. So there are no false positives. And cannabis also, which is THC, is metabolized to 11-hydroxy-THC, which is the primary active metabolite, and the THC carboxylase, and that's what we test in point-of-care testing. That's the primary urinary marker. And then we have the confirmatory testing, which is gas chromatography and mass spectrometry. And then we have the liquid chromatography and mass spectrometry. So when you collect a point of care specimen, if you need to send them for specific testing, confirmatory testing, that's what we generally do, is GCMS or LCMS. Next slide, please. So what is mass spectrometry? It's a highly sensitive, capable of detecting even minute quantities of a given substance and able to create highly specific mass spectra for the compounds that it clears. Prior to entering a mass spectrometer, the substances must be ionized, usually by bombardment with electrons. The mass spectrometer then uses electromagnetic filtering to detect ions of a specific mass to charge ratio by a detector. By scanning the range of masses that pass through the detector, a mass spectrum is generated, and the mass spectrum of any compound is highly distinctive. It's like fingerprinting. And as a result, the mass spectrometer is usually considered to have the highest specificity of all lab detection methods and usually part of the confirmatory test method. Next slide, please. Next slide, please. So what do we look for in a urine sample? So when our clinic staff collect a urine sample, first things we are looking for is appearance. What is the color of the urine? Usually samples can tend to be from pale yellow to darker yellow, depending on what time of the collection it is. Morning samples generally tend to be more concentrated as compared to afternoon and late afternoon samples where people have consumed drinks, fluids. They tend to be lighter yellow. So appearance is important. If urine just looks like water, and that is again a kind of red flag. Within 4 minutes of collection, urine temperature is between 90 to 100 Fahrenheit. All point of care testing sample bottles have a temperature monitor at the bottom. There's a temperature strip at the bottom, which gives you an indication of the temperature. But like I said, and even our clinic staff, they will, they're using gloves and they collect the sample and they immediately feel for the temperature. Now, just come by and sometimes it's just cold and they will send me a message and Dr. Wakhlu, I collected a sample, but there was no, so like I said, human urine should be between 90 to 100 Fahrenheit within 4 minutes of collection. pH is generally between 4.5 to 8. Specific gravity is from 1.003 to 1.030. And the urinary creatinine concentration is generally of human urine is greater than 20 milligrams per deciliter. If it's less than 20, it's generally dilute urine, and if it's less than 5, it's not human urine. Most likely, I had one instance where a patient got their dog's urine and brought it to the clinic and kind of slipped it in, and when the lab tested it, they said the creatinine concentration was less than 5. So, and then he admitted to that's what he had done. Yeah. Next slide, please. So now, next few slides, I'm just going to talk about the metabolism of various substances, and these is just generally talking about the breakdown of benzodiazepines. If you look closely at diazepam, oxazepam, temazepam, and chlordiazepam oxide, as you can see, the final metabolite of all these 4 benzodiazepines is oxazepam, of course, and so that is what the if someone is taking diazepam or Valium or taking Librium or chlordiazepam peroxide or temazepam, oxazepam, they'll finally the end product is oxazepam. So the confirmatory testing will show you oxazepam. Alprazolam is broken down into 11 alpha hydroxy alprazolam. Clonazepam is broken down into 7 aminoclonazepam, and lorazepam or Ativan just undergoes glucuronidation to lorazepam glucuronide. So you can actually specifically differentiate between different. So that becomes important for patients who are taking on chronic prescriptions for benzodiazepines, that say someone is taking clonazepam, they should have 7-aminoclonazepam as the confirmatory testing and not oxazepam. If they have oxazepam, then is a time for a discussion with the patient. So that's it's important to know the breakdown of each specific benzodiazepines. Next slide, please. Opioid metabolism. And there are 3 opioids that primarily show as breakdown into morphine, which is morphine itself. If a patient is taking MS-Contin on any morphine compound, they break down as morphine. People who are using heroin, heroin is primarily diacetyl morphine, it's a prodrug. It gets rapidly metabolized to a substance called 6-monoacetyl morphine, which then quickly gets hydrolyzed to morphine. And it's very hard to find 6-MAM in urine because 6-MAM has a very short half-life. Half-life is about an hour or so. So it's very hard to find 6-MAM. So people who are using heroin, primarily they show positive as morphine. And then codeine. Codeine is methyl morphine. You take the methyl chain out, the codeine gets broken down into morphine. So only 3 compounds, 3 opioids that will show up positive as a morphine. Others should not. So methadone gets broken down into what we call EDDP, or the methadone metabolite, fentanyl into norfentanyl, meperidine or Demerol into normeperidine. Hydrocodone gets broken down into hydromorphone or Dilaudid, and tramadol into O-desmethyl tramadol. So these are just the common the pathways of breakdown of some of the commonly used opiates. So again, it also helps you differentiate between different opiates. Buprenorphine gets broken down into norbuprenorphine, and not there on the slide. So that helps you differentiate between the different types of opiates. Next slide, please. Just spend a slide or 2 on alcohol testing. We have 2 alcohol testing. One is ethyl glucuronide or ETG, or ethyl sulfate or ETS. These are minor metabolites of alcohol. They are present in urine 80 to 120 hours after the last drink. And any ETG or ETS value of greater than 500 nanograms per ml is significant for alcohol use. And you can get false positive due to extraneous exposures, which can be due to alcohol-based hand sanitizers, but use 20 times more in a day. Mouthwashes, when they are swallowed, consumption of pralines, non-alcoholic beer, sauerkraut, and kimchi can also cause a false positive. But usually people who are drinking on a regular daily basis, their ETG, ED levels are generally greater than 50,000 nanograms per ml. So I have patients who are drinking daily or almost daily. Generally, if you get levels between like 2,000 to 5,000, and these are people who are drinking once or twice a day or 3 times, once or twice a week or 3 times a week, and they're drinking a couple of drinks, they're usually in that range of 3,000 to 7, 8, 9,000. But daily, heavy, regular drinkers usually have ETG, ETS levels of greater than 50,000 nanograms per ml. Next slide, please. Oh, sorry. This should the slide should have said PEth and not. So another alcohol testing, which I like to call the A1C of alcohol testing. It's the A1C of diabetes is would be called PEth or serum. It's a blood marker. It's a serum marker. It's a phospholipid. It's an abnormal phospholipid that's formed on the surface of red blood cells by a reaction caused by phospholipase D in the presence of alcohol and phosphatidylcholine. And PEth can be detected within 1 to 2 hours post drinking and peaks in about 8 hours post ingestion. Once formed, it slowly degrades in about 12 days. Half-life is about 4 to 10 days. And PEth has a window of detection, which is about 2 to 4 weeks, generally 4 weeks. And if people are chronic daily drinkers, then PEth they have higher PEth levels, and PEth lasts for much longer. Next slide, please. So this is how you compare PEth. Any PEth of greater than 20 nanograms per ml means some level of alcohol use. Less than 20 is a negative. But then it shows you different levels of less than 80 is about 4 drinks per day. Greater than 80 is about 4 drinks per day. Greater than 221 is about chronic and excessive use. Greater than 400 is again daily heavy use. And people who get DWIs generally have a PEth level of over 700 nanograms per ml. The highest PEth level I've seen in my practice is I had a professional with a PEth level of 2245. And that's the highest I've ever seen. Now, as you can see, these are different cutoffs. A good way to remember this is that generally, if a PEth of 100 means the person is drinking at least 4 standard drinks on a daily or regular basis. So that's how I remember it. That's the easy way to remember rather than kind of trying to remember different numbers. Next slide, please. False positives. Again, false positives kind of become a big issue, especially when it comes to the amphetamine class. We have several agents that can cause a false positive. If people consume ephedrine, pseudoephedrine cough syrups, people who are taking selegiline, which is a MAO-B inhibitor, it's used for as an antidepressant, used for Parkinson treatment, and phentermine, which is a diet pill, can all cause false positive on the point of care testing. And the confirmatory testing can help you differentiate between methamphetamine, amphetamine, pseudoephedrine, selegiline, phentermine. So that's how confirmatory testing is helpful. Cannabis, neverapine, almost 100% causes a false positive for THC. It's such a problem that the drug company has put up in the packet insert. They have said, if you're going to get a drug test, please let your doctor know, because you're always going to test positive for THC. It's a false positive for THC. Opioids, quinolones are antibiotics. Levofloxacin, norfloxacin can trigger a false positive for opioids. Naltrexone can trigger a false positive for opioids, because naltrexone comes from an alkaloid which is present in raw opium called thebaine. Thebaine is also used to make oxycodone, hydrocodone, buprenorphine, oxymorphone. They also all come from thebaine. So again, they come from thebaine, so structurally similar. So naltrexone. So a patient who we have prescribed naltrexone for an opioid use disorder or for an alcohol use disorder can sometimes on point of care testing trigger a false positive for opiates. And then again, if you do a confirmatory GCMS, LCMS, it helps you differentiate between naltrexone and other opioids. And rifampin is the medication that we use for TB treatment that can also trigger a false positive for opiates. There are no false positives for cocaine. Like I said earlier, if someone tests positive for cocaine, it's 99.99% that they've done cocaine. So I never get confident testing for cocaine. Now, if a patient absolutely vehemently denies it and says, no, I'll send it for confident testing. And again, it always comes back positive, but generally I don't get. And sertraline or Zoloft being false positive for benzodiazepines is a myth. It's a myth that was circulated by a poorly written article on drug testing, and it does not happen. I have a lot of patients taking Zoloft or sertraline. It does not happen. I've done an extensive search of the literature. That's a myth. That doesn't really actually happen. Next slide, please. So again, my last two slides are primarily on how to discuss drug testing. When you're seeing a new patient and you're initiating treatment as part of your treatment agreement discussion, this is a routine practice as a patient safety issue. We need to be able to follow whether treatment is working. This is consistent with standards of care. So those are some of the conversations that you can have about patients about when you're a new patient initiating treatment. A patient who has been in treatment for a while, say, why now? It's a new clinic policy. And like in our clinic at UT Southwestern, we initiated a new policy on patients on chronic stimulant treatments requiring annual or as needed drug testing. Is a new policy that we put in place about a year back. So again, new clinic policy. The guidelines are clear that this should be done to determine whether treatment is working and help us adjust our care appropriately. Next slide, please. Patients may say, well, I'm not a drug addict. And again, it's routine testing. It's not singling everyone out. This is consistent with our standard of care. And we need to be able to determine that our treatment is working. Again, this is what we as we initiated this testing in our clinic, this kind of became patients came back and said this, and again it's like I said, it was presented as a standard of care, a routine practice. Patients who refuse, and then patients who refuse these conversations like, we can't prescribe certain meds if you're unable to do routine safe monitoring, discuss in treatment agreement. Also, we're not here to judge, but we need to treat addiction as a disease and test accordingly. So those are some of the discussions that you can have with patients about drug testing. And clearly, like I said, it's not a caught you tool. It's not a punitive tool. It's a tool to help you with patient management, a tool to help you with patient safety. So if you're patient on a stimulant, on Adderall, Vyvanse, Concerta, if they're positive for cocaine, it's time for a discussion. Again, it's a patient safety concern, and what other treatment, what other options, what other treatments are available for this patient to help them with their cocaine use, if it's determined to be a problem. So again, like I said, patient safety tool and a tool to improve overall patient care. And I think this is my last slide.
Excellent. Dr. Wakhlu, thank you so much for this comprehensive presentation on drug testing options and things to look out for. At this time, I'd like to open the floor for any questions from anyone in the audience for Dr. Wakhlu. I did see a question come through from Marquis Deal regarding fentanyl false positives. Marquis, did you want to unmute and perhaps elaborate on that? If not, no worries. I can ask on your behalf. What I saw come through was any false positives for fentanyl, Dr. Wakhlu?
Not to my knowledge. And again, if a patient is denying fentanyl use, like I said, you can always send the sample for an opioid confirmation, which will show the presence of both fentanyl and norfentanyl. Like I said, not to my knowledge, I've not had any instances of false positives with fentanyl. Yeah.
Thank you. And as a huge poppy seed bagel fan myself, can eating poppy bagels cause false positive during drug testing?
If you eat a lot of them, yes, and because poppy seed bagels, and then the poppy seeds themselves, is that because when you look at how is the opium harvested, you have You have the poppy flower. As the petals fall off, this pod in the center keeps growing, and this becomes this huge poppy pod, which is then lands to get raw opium. Inside of the poppy has seeds, which we use for cooking, and so during the process of this, the seeds get contaminated with this raw opium. As you all know, raw opium contains uh, morphine, codeine, and thebaine, and so that morphine can get that seeds get contaminated. But if you eat enough of them, so that the cutoff goes higher than 300 nanograms per ml, yes, you can turn it positive. But then, if you do a confirmation, it should only show morphine. And it should not show hydrocodone or hydromorphone or any other opioid. So yes, if you eat enough of them, yeah, which passes the cutoff mark of 300 nanograms per ml, but it would not be a positive on the federal drug testing because there the cutoff is 4,000 nanograms per ml. It's a much higher cutoff. But on routine clinical testing, yes, you may test positive for morphine alone. Yeah.
Thank you, Dr. Wakhlu. James Easter asked if these slides will be available or if they can view this recording. Yes, to both. The slides will be shared in a post-session communication email, and the recording will be also available on the Be Well Texas website for reference. And Rashna, I do see a comment from you. Could you unmute and ask your question, please?
Yes, thank you for a great talk, Dr. Wakhlu. This is Rachna Goswami, palliative care at UT Southwestern. I often have patients who are prescribed low doses of opioids that they use just sparingly, maybe a few times a week intermittently. And sometimes I'll have urine drug screens that are negative, and I'm not sure sometimes like what to make of that urine drug screen, whether it's just not detecting their level of use or whether I should actually be concerned about diversion or something. And so I guess one question is the primary way to handle these situations to get the confirmatory opioid testing? And then the second question is, do you have any idea, like when I talked to the lab about thresholds for screening detection, they were talking to me in terms of like nanomoles per ml concentration in the blood of what somebody would need to have to detect positive on a UDS, but that clinically didn't mean anything to me. So do you have any sense of kind of how many MMEs, OMEs somebody needs to be on daily to be detected positive on a urine drug screen for opioids?
So, Rashna, thank you so much. I couldn't tell you an answer on MMEs, but I will say this: if you get and these are patients you are saying they're taking opioids intermittently, right? Not on a regular basis.
Correct.
All right. So one thing is if you get a point of care testing that is negative, I would definitely send it for confirmation. There's a drug test in our Epic system. It's called pain confirmation, pain management confirmation. Order that and give you the entire spectrum of all the breakdown of all compounds. So you should definitely get that as a good practice. I mean, you're prescribing opioids to them. You should definitely they should have a confirmation, even though you don't suspect any. There are no red flags or anything. You should at least once a year have evidence showing that the patient is being prescribed hydrocodone and you are finding hydrocodone and hydromorphone in their urine. I think that's one good practice. Second
Yes.
is if you have concerns, then what we do in our clinic is we'll sometimes do like a random callback. We will call a
Mhm.
patient up and says, please come to the urine. Please come to the clinic. You have 24 hours to come to the clinic with your buprenorphine. The only opioid we're doing here in the addiction clinic is buprenorphine. So we're not
Mhm.
prescribing it. So they
Mhm.
have 24 hours to come to the clinic along with their buprenorphine bottle. So we can do a pill count and then we
Mhm.
collect your urine at that time. So that's another practice.
Yes.
If you have any kind of if you're worried about the patient, is there any red flags?
Perfect. Thank you so much. That's very helpful. I appreciate
Of
it.
course. Thank you.
Thank you both. And I do want to highlight Lindsay's comment on if someone is still testing positive for substances, that may be a good indicator that they need an increase in their medication, not to be taken off of it. And so I do invite you all to continue the questions for Dr. Wakhlu and comments on his presentation while we move on to announcements. And Dr. Wakhlu, I point your attention to the chat in case something comes through while we go through those announcements. Thank you. Thank you so much, Karen. So to claim your CME credits, please ensure you have a registered account and then text attend 100-99718 to the number 844-502-1338 no later than midnight tonight. Next slide, please. CSAT offers you all the opportunity to present any challenge your organization is encountering and to receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation as we do provide you with the case to fill out in order to assist you with the case presentation itself. Please email us using the link in the chat if you or someone you know is interested. Next slide, please. Our hearts are with the Kerr County and surrounding communities that were affected by the recent floodings this past weekend. If you or someone you know has been impacted by the flood, or if you would like to help, this list of resources is available to support local families during this time of recovery. You can scan the QR code or go to the link at the bottom right of the slide in order to navigate these services. Thank you. The Center for Substance Use Training and Telementoring by Be Well Texas is still accepting applications for our mood mentoring program. We invite you to join us for this exclusive opportunity that's designed for prescribers to receive personalized one-on-one mentorship in order to integrate mood services into daily clinical practice. This exclusive offer is available to a select few in the Texas Public Health District Region 8. So don't miss this great opportunity. To take advantage of this opportunity, simply visit the application link that is shared in the chat or email us. Next slide, please. And I'll pass the mic over to Dr. Bone.
Thanks so much. My name is Curtis Bone. I'm an addiction medicine physician here at UT Health San Antonio with Be Well Texas, and also a researcher. My research is focused on testosterone deficiency in people who use opioids. This may be a future echo that would be informed by the survey that I just left in the chat. It takes about 5 minutes to complete, but if folks on here are able to complete that survey, that would be super helpful, both, like I said, for research purposes and also to inform future educational efforts. It's open to MDs, DOs, NPs, PAs, people that prescribe opioids or take care of people who use opioids. Thanks so much.
Thank you, Dr. Bone. If you're interested, you can apply using the link that is in the chat or reach out directly to Dr. Bone at his email that is also on the slide for more information. Next slide, please. Thank you. The Texas Substance Use Symposium is back on March 2nd through the 3rd of 2026 in San Antonio, Texas. We are thrilled to reunite our statewide community once again at this event. We're also excited to introduce a new Texas Regional Summit this fall in El Paso. If you're in the area or you'd like to travel to the area, please stay tuned for more details that will be shared soon. And for the latest updates, visit TxSUS.org. Next slide, please. Thank you. Join us for our next Texas session with speaker John Komola on a discussion on how to evaluate and navigate through today's policy and funding landscape. Register today by either scanning the QR code that's on the screen or visit texas.org/sessions. Next slide, please. And finally, please do join us at our next session on July 24th for a presentation talking to patients with substance use disorder and navigating stages of change with Dr. Janine Ramesh. Thank you so much. And so with that, I will pass the mic back to Dr. Wakhlu, our case presenter for today. Once Karen shares the slides, Dr. Wakhlu, please walk us through it. Thank you.
Thank you so much. So the reason I wanted to share this patient is I would really like some input from the community regarding any other psychosocial interventions or any other pharmacological interventions that might benefit this patient. So this is a 43-year-old Southeast Asian male who has been seeing me for the last 6 months. So came for a new patient evaluation about 6 months back, and his presenting complaint was primarily pornography addiction. And he would spend excessive hours watching pornography, spending money on sites. It was interfering with his relationship with his wife, and he was taking him away from his kids. And clearly a problematic pattern of pornography watching and sex addiction. No substance use history. Initially denied any history of depression or anxiety. History of childhood trauma from the ages of 7 to 11 by a family member, and this was his first time ever seeking treatment. He'd never been in therapy before, never never sought any psychiatric care, and was quite distressed when he said, and I'm sorry, I take it back. He had seen a CSAT from a few times before he came to see me, and so then he presented us to see me, and what I did was I started him on a combination of fluoxetine and naltrexone. So what I did was I started naltrexone week 1. I started on 25 at bedtime for 7 days, and I went up to 50. And then week 2, I said, once you have taken naltrexone for a week, then start fluoxetine 20 milligrams daily. So that's what I did. And then he returned to see me in about 3 to 4 weeks. He reported that with the fluoxetine, he had less obsessive thinking. The naltrexone primarily helped him with the compulsive behaviors, and though he still had slips and relapses and episodes of use, and then he started. I said, you need to reach out back to your CSAT and get in therapy on a regular basis. I suggested that he go to SA and SLLA meetings. So when I saw him back in the MAC, in a month he had tolerated both medications well. Like I said, there was clearly a decrease in his behaviors, and he had started going to SA meetings. He had a sponsor. He had reached out to his CSAT therapist, but couldn't get an appointment with him. And then he found another therapist that he started, who was not a CSAT, who was not, but he said I liked him, so he started seeing him, and then ever since then, I have been seeing him every 3 to 4 weeks. The second visit, what happened was that he said things are fine, but I'm still having episodes. So I gradually increased his naltrexone to 100 milligrams, and then I told him you can take up to 150 for any high-risk situations, any periods or times, which was primarily every time he was under stress from work or he had some downtime, boredom was the times that led to his slip and relapse. And then at the third visit, he said, I'm okay on the I'm happy. My wife says after being on these medications, I'm easier to be around you. She commented that he looked happier. He was a better person to be around. So initially he had denied any mood symptoms, but I suspect he had some underlying depression that he didn't really talk about. So, but then the third or the fourth visit, what he said was, it was not a visit, it was a my chart message he sent me. He said, I feel I'm having sexual dysfunction from fluoxetine. Second is, I'm feel amotivated. I just don't. So what we did at that time was I slowly tapered him off fluoxetine. I put him on vilazodone, starting with 10 and gradually titrated up to 40. After about 4 weeks of vilazodone, he said, I just can't take the vilazodone. The nausea was he just couldn't tolerate the nausea. Even decreasing the dose to 20, he couldn't tolerate the nausea. And then he, at the last visit with me, he said, I would like to go back on the fluoxetine. So tapered him off the vilazodone, put him back on fluoxetine 10, just on 10, and then he says, this is really better. And then uh, 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 I increased it to 15. I didn't want to go up to 20 because he had that and on 10 he didn't have no sexual dysfunction, and but still some room for improvement. So I said, let's not go from 10 to 20, because at 20 you had the sexual dysfunction. You also had the A motivation. Just stay on 15. So this is what he's on right now, is the fluoxetine 15, which, like I said, helps with obsessive thinking. And naltrexone, generally 100. He takes 50 BID, but he can take up to 150, which have clearly, there's been a pattern of reduced compulsive behavior. So he's clearly better. Still has some slips here and there, but the slips are much shorter duration. They're only 15, 20 minutes, as compared to when he could go hours watching porn, and then ignored his work and his family responsibilities. So, and like I said, a better relationship with the wife. I have invited his wife to come for appointment. I've told him, I said, your wife is welcome to. She has not come. I've seen him about, like I said, 6 months. I've seen him about 6, 7 times. She hasn't come for appointment yet. I've suggested couples therapy, but I think they have chosen that he do his own therapy, and then and she's found a therapist for herself. So, and recently, he was started seeing a therapist, and for somehow they didn't click well. And then I have referred him to. He said, Dr. Wakhlu, I want to focus on trauma work, so I've referred him to a trauma therapist here in clinic. So that's where we are. Like I said, he's clearly better, but he's not well. I mean, like, it's not well in the sense of there's not an absolute absence of sexually compulsive behavior. It is much decreased. He has definitely a better quality of life. Things at home are better. But so that's again. So again, I just wanted to kind of throw it out to the community and see what else, based on your experiences, what else could help. And yeah, thank you so much.
Thank you, Dr. Wakhlu. And the floor is open for any follow-up questions or comments from the audience for Dr. Wakhlu.
So I was not very experienced with process addiction, so I'll just put that out there up front. But I was looking this morning, reading the case ahead of time about any literature in process addictions around contingency management. There seems to be a small bit, mostly around gambling. I think this is a huge area that's open for research questions, although I'm assuming the funding's just not there, or it would be done already. But I'm wondering if that's something to try with this person, and if that would make an impact. There is a bit more literature on contingency management for substance use disorders being especially effective for folks with a trauma history. And it sounds like he does have a trauma history. So that's where I kind of was my entry point to think, well, maybe CM for him.
Yeah, thank you. Thank you. Really appreciate that. Yeah.
Thank you, Dr. Kowalczyk. I was wondering if anyone in our group today has had any similar experiences with, process addiction cases, and if you've tried anything that has worked or even hasn't worked. We're open to any and all experiences with this.
I think something I do encounter more frequently is, and maybe I'm encountering someone with a sexual addiction as well, and just not doing a good job of identifying it. But high sexual activity and risk taking in patients, particularly using certain substances. And I don't know if that might resonate more with folks here and what they're seeing clinically. So this person doesn't seem to be using substances, but definitely in my patients with stimulant use disorder, using a lot of nitrous oxide, MDMA, see a lot of that. And sometimes it's something that they bring up as a concern, most of the time not. And then I don't usually do a great job about following up after, that we've gotten their use disorder a little better managed. So maybe again a gap in care.
Dr. Qualter, you bring up an excellent point. Is for my patient, he clearly has a primary sexual addiction. In the substance abusing group, it becomes sometimes difficult to tease out whether this is a primary sexual addiction or is it a hypersexuality secondary to meth use and the acting out behavior. So that becomes sometimes hard to tease out. Yeah. And a clinical challenge.
Any other thoughts or comments from our attendees?
If there are no other questions or comments from the audience, Dr. Kowalczyk, if you could give us a brief summary of today, please.
Yeah, so we started out the hour with Dr. Wakhlu presenting on an update on drug testing and how to use that clinically in care of patients and in support of their substance use disorder recovery. Different options, some pitfalls to various options and limitations. Also some common false positives and things we see cross-reacting and don't. And then a kind of good discussion, particularly in the chat, but starting out with Dr. Wakhlu presenting on some approaches to communicating with patients around drug testing in a supportive, non-punitive way. And then again, just really great discussion in the chat that when it's not done right and in support of someone and their chronic illness of a use disorder, it can be really detrimental and have a pretty negative impact. And when used appropriately and in a patient-centered way, it can be really helpful to escalate, help people get additional treatment, including medication treatment or dosing, and also to identify people that are at risk of harm and imminent harm from medication and appropriately intervene. And then we transitioned into a very interesting case on sex addiction and realizing there's really limited literature base on this. And it's an area ripe for study, but things to consider are treating comorbid substance use disorders, comorbid depression, trauma therapy, any other underlying psychiatric illness, and then naltrexone off-label for helping with that with sex addiction and the SSRIs, particularly fluoxetine for impulse control. So that's what we talked about today.
Thank you, Dr. Kowalczyk. I do see a comment from Lindsay that came through. She did have two friends that were kicked off their MAT program for cannabis use, and both unfortunately died from an overdose. And um, my hope, and I think the hope of Be Well, is that conversations like this, help make that less and less of an occurrence in our communities, in our society, so we stop losing loved ones, and we get more access to help and better care, and hopefully we raise awareness with these sessions. So thank you, Lindsay, for sharing that, and I speak on behalf of everyone. We're so sorry that that was something that happened. Thank you to everyone that has attended today's session. As a reminder, to claim your CME credits for today, you must text by midnight tonight. Text to 10-100-99718 to 844-502-1338. We kindly also request that you complete the post-session survey using the link in the chat. And we do look forward to seeing everyone at our next Echo session on July 24th. Have a great rest of your week, everyone. Thank you.